Thank you. So, what I wanted to talk to you all about tonight was managing sensitivity and tooth whitening, because up to 80 to 85% of patients can experience some type of sensitivity during tooth whitening. And so we should have strategies and protocols to manage their sensitivity. There's also a vast amount of patients who, in general, report to you that they have sensitive teeth. And I feel very strongly that we shouldn't just leave them to have their sensitive teeth, but we should have some protocols to help them manage their sensitive teeth. And so, what I'd like to share with you is some strategies tonight to assess for patients going forward and what we can achieve for them. Now, let's just see. Okay, so what I wanted to do is look at how we can treat the sensitivity before, during, and after whitening, what strategies we have, what we need to look for when we're assessing our patients and doing our intraoral examinations. We're very excited now from the 29th of March that our patients will be coming rushing back to us, and our appointment books will be so full we won't know what to do, which will be very welcome, I'm sure, from all the dentists and hygienists. So we want to talk about whitening, the use of different materials, and the management of sensitivity. The first question is, can we predict which kind of patients are going to be sensitive during tooth whitening and after tooth whitening? So before we start, there's a couple of common mistakes that most dentists make with bleaching treatments. Most of them have no training and haven't learned the science and research. As a result, that they don't have any knowledge on bleaching protocols and strategies, which is why we set up the British Dental Bleaching Society to help with this. The next thing they do is they don't do comprehensive treatment planning and adding value service for their patients, because bleaching is the first part of the treatment plan. And then again, they looked at research. 85% of patients come back and ask for further aesthetic dentistry after having their teeth whitened. So what was happening is that we found many dentists just make it up as they go along. When they are doing tooth whitening, they just try a bit of that and a bit of this. They think the treatment is over in 2 weeks and it's only beginning. And so the practice principal who's had no training on whitening will tell his associates who's had no training on whitening, and everybody just makes it up and they just wing it. But actually, there's a vast amount of a body of science and information where they could learn and develop some strategies. The next thing is, do not compromise your professionalism in any way by undertaking inappropriate treatment. If a patient is bullying you because they want Love Island shade white teeth to achieve that, or a bleacherexic patient where you know that's not going to be appropriate or not achievable, we need to be honest and candid with the patient to discuss what can happen and what's not going to happen with whitening. And if it is that they want Love Island shade white and that need 20 veneers, that is a different story. Many dentists also don't understand the difference between carbamide peroxide and hydrogen peroxide when they're administering the bleaching gel. So we can talk about that as well. And most dentists undertake the whitening treatment for too short a period. So they think that 2 weeks is the maximum treatment time, but actually 2 weeks is when it's only beginning. And we use the Hayward Protocol, and that is a 4 to 6 week treatment protocol. Often dentists start by doing the 16% carbamide peroxide straight in, and that because of the high concentration, the patient may not reach the bleaching potential of the tooth, and the tooth is always regressing in shade. It's moving up and down on shade, which we need to use a 10% carbamide peroxide and slowly increase the whitening. Some dentists advise their patients to top up monthly, and that is not necessary either. The reason that they do that is that the tooth never achieved the actual bleaching potential of the actual shade. Do not just give all the bleaching syringes and the trays and just say, see you in 6 months. You need to follow up, and it's normally 4 to 6 appointments to manage this treatment protocol with the patients. And therefore, they don't charge enough based on their time and their service that they provide for patients. There's no action plan for introducing whitening into your practice. That means the whole team need to be involved. That means after you've done training, you need to sit with the receptionist and the hygienist, for everybody to be involved, doing the admin, understanding what can happen, helping patients manage their sensitivity, helps with the strategy. So the whole team needs to have whitening, and everybody on the front desk, again, whitening they should try the whitening and have the look at the treatment. So here is a typical patient who has got recession sensitivity, chipped and fractured restorations. So on a patient like this, what we would do first is in these areas where they have these deep cervical lesions, sometimes we call them NCCLs or recession, and here the patient has a lot of recession. What we would do here first, before starting any whitening, is we would do a resin modified glass ionomer to build up the teeth and to cover these areas here. Then we would take our bleaching trays to make the tray, but we would need to fill this in. If you're going to do a bonding afterwards, we would fill this in temporarily, repair this, repair this, repair this, and then especially this deep lesion over here, and then we would take our impressions for the bleaching trays so that these areas here, which are super sensitive, can be covered over. When they looked at who is going to be sensitive with whitening, they did a long Cochrane study, and they've done a lot of research collaborating all the sensitivity studies, and they found that it was very inconclusive to understand who is going to be sensitive and who isn't. Just because a patient's got abrasion, defective restorations, that it may not necessarily mean that those are going to be the patients who are sensitive. But the protocol showed that those patients who had the protocol where they bleached in the morning and the evening, those were the ones that were most sensitive. So if you're going to discuss your bleaching protocol with a patient, they shouldn't be doing half an hour morning, half an hour evening, because those are the ones who are going to be more sensitive. So what we did for this patient is we did the restorations, we whitened the teeth. This patient is a tetracycline patient. And so the bleaching is going to take longer and slower, and we started on a low concentration. We built up to a higher concentration, and at the end we repaired, and then afterwards we did gingival grafting. We didn't do gingival grafting immediately to repair the sensitivity because that's quite an invasive procedure, and so we did it in a simple way. So why do patients have sensitivity? And we also need to look at the difference between sensitivity and pain. So sensitivity could be related to abrasion, attrition, and erosion with tooth wear, any acid defects, extrinsic and intrinsic, dietary acid, regurgitation, and eating disorders. And often I find many patients who use an electric toothbrush tend to be a little bit too aggressive, and they have a lot of recession. So on those patients who're super sensitive and they tell you they've got the latest electric toothbrush, we try and encourage them to just use one brushing session electric and one manual with a super soft toothbrush. So we can train them on not pushing too hard to cause a recession. And then also those patients who have fractures, micro cracks, cracked teeth, and cracked cusps, those ones can be more sensitive because we now know from research that the whitening gel goes into the weakest part of the tooth first, which is often a crack in a tooth. So if you have a bruxing patient, you need to make a thicker tray, but you need to monitor them quite carefully along the way. If they do tell you they have sensitivity prior to whitening, we need to look at a way to manage that. And on patients with multiple wear problems, again, we need to look at that, but we really want to exclude the difference between sensitivity and whether they have a pulpitis. And we want to look at questions about sensitivity to hot, because sensitivity to heat means there's a pulpitis on one tooth. Sensitivity to cold means that they either have gingival recession. Sensitivity to cold and pain on biting is a crack, and that needs to be treated. And sensitivity to sweet, as you know, is caries. And so all that we need to look at. But we need to look at, because some patients, they tell you the tooth is sensitive, but actually they've got a raging pulpitis, and others hardly have major pain where there is very little evidence for the pain. And so we need to look at how we can treat this, but we do know up to 85% of patients experiencing sensitivity, whether it's sensitivity on the teeth, sensitivity on the gums, sensitivity on the mucosa, or the soft tissue. So we want to look at how we can protect the patient's root surfaces, and also how we can use aligners and how we can manage sensitivity. So one of the first things is that the research study from Van Hayward showed brushing with a desensitizing toothpaste makes a significant difference for 2 weeks prior to whitening. So for those patients who are super sensitive, the first thing we'd do is put them on a protocol of toothbrushing with a desensitizing toothpaste. Now, the two main desensitizing toothpastes are Novamin, which is the GSK product, the Sensodyne, and the arginine. And arginine is in the Colgate Soother. So those two agents act by blocking the tubules. So coming back to the patient, we do need to ask these questions very specifically. When they tell you, when a patient asks you that they want to do whitening, we would ask them the next question we would ask them is, do you have any sensitivity? And after that, we would ask them if they had sensitivity to cold, to sweet, to heat, to pain again, because all of these mean something. And cracked teeth are very common, particularly now during COVID, because more patients have been grinding their teeth. We find that we're providing more bite plates. We're very lucky that we've got a 3D printer now, which can print the liquid resin straight onto the bite plates and with software. So we're making a lot of bite plates. But the cracked tooth syndromes we do need to look at because that can exacerbate with patients with who are whitening their teeth. So the pre-treatment options would be to assess the etiology of the sensitivity, sometimes do nothing and monitor. As we mentioned, monitor, modify the toothbrushing technique, and then they apply the desensitizing toothpaste. The other ones are the Durafat, as well as MI paste and tooth mousse, and Biomin and rocks as well. All of these are desensitizing materials, and there's one from Vivadent. Then what we would do is we'd make a bleaching tray for the patient, not for the purpose of bleaching, but actually for the purpose of desensitizing the patient. So we would use the proprietary desensitizing gels into the bleaching tray for specifically for the purpose of desensitizing the teeth. No whitening. For 2 weeks, the patient would do this. They would have a protocol of 45 minutes a day wearing a desensitizing material in the tray to soothe the teeth, upper and lower. They can do upper and lower at the same time. And then they would be using their Sensodyne to brush with. And another technique is using the MI paste and massaging that into all the cervical surfaces to encourage desensitization. We will then often need to do restorative treatment, as we showed you, monitor the toothbrushing habits, and where there is exposed dentine, we could do the following. We could put Gloomer or Hurry Seal to drip onto the exposed dentine surfaces. We may want to do a composite on a class 5, but my treatment of choice is the resin modified glass ionomer, and I will show you how and why and discuss the protocol. You can also apply SDF, silver diamine fluoride, onto the cervical area because it's has a license for sensitivity. And depending if you need to treat cracks, whether you have to do onlays prior to whitening to hold the crack together. So all those are treatment strategies. So we also want to, first of all, manage pain and pain versus sensitivity, which we discussed. Then there's issues with gingival irritation and ulceration. We don't often tend to see much gingival ulceration these days because our trays are well fitting, they're scalloped, there's no reservoirs, they fit nicely, or we're using Invisalign retainers. And so we don't often see ulceration. We would see gingival ulceration if the patient is using too much gel, and sometimes we need to cut back the tray and modify the tray, especially around the central papilla. We can get uneven bleaching, which is known as the splodge effect, where with the incomplete bleaching, you bleach the weakest part of the tooth first, which may be a white spot or a defect on a tooth. And again, that needs to be managed as well. Then we have the white spot management, which is a specific protocol on its own. And up to 25 to 40% of teeth erupting now have white spots on their teeth. And this applies to children. And this is why we need a protocol for the kids and for management. Of course, we need to do caries management for our patients prior to whitening because they can't just rush in to do whitening if they've got large cavities which are going into the pulp. And we need to assess to make sure there's no undiagnosed periapical lesions. Now, Kilbasa did one of the systematic reviews, and they looked at tooth sensitivity during and after tooth bleaching. And they said it's basically an unsolved problem, but there are strategies that we can look at. One of the little controversies about amalgams fillings is that during whitening, you have significantly more whitening, more mercury released during whitening than if you don't do the whitening. And so this is a controversy which needs to be discussed, but doesn't lead to sensitivity. It can lead to little black occlusal little stars in the patient's bleaching tray. It's just a discussion that we need to have. But basically, most of the pain is coming through to some type of crack, defect, or the cervical area in the tooth. And we need to understand that, particularly patients who are bruxes on the lower incisors, on the lower incisor teeth, those can be sensitive during whitening. So our treatment protocol would be number one, stage one, which would be prevention of the sensitivity. Stage two would be treatment. We need to do some type of treatment, and of course, we need an avoidance of the sensitivity. And what we want to do is establish patients to monitor them by self-managing the problem, and we give them the different materials to use, and we give them the strategies and options so that it becomes the patient's problem, not the dentist's problem. On this particular patient, this was also an under 18 patient with tooth discoloration, quite severe. Um, um, she was devastated with the shade. Both of these teeth, one of them was non-vital. They'd been traumatized. This is a specific case that we classified that this should be treated under for whitening, underage whitening. It's appropriate to whiten these teeth. So this patient here, she had the root canal treatment, not by us, but previously done, and she has calcific metamorphosis on the other tooth, which is vital. We did non-vital bleaching here, special whitening on that tooth to get this result. So we have this thing called the day 3 rule. The day 3 rule is that the patients have the most sensitivity on day 3. And the reason for this is due to the fact that there's maximum saturation of oxygen inside the canal on this day. So we pre-warn patients when we're administering on the first stage bleaching, we pre-warn them and we tell them that on the third day it's going to be really sensitive and not to worry because after that it will be less. And we ask our patients to document and do a log of their sensitivity. And if you need this patient log, I'm happy to send it to you. Diane will send it to you, plus our consent forms, plus our what to expect leaflets for patients of commonly asked questions, so that's very clear what to expect during whitening. So the way that the materials work is they either act, we have potassium nitrate fluoride, ACP combinations, Novomin and arginine. They block the tubules of the tooth. For example, where you can see there's hollow tubules here, the materials act as tubular blockers. But they only work for a general period of 2 weeks, and then we suggest that you change the toothpaste. And you do 2 weeks of Novomin, 2 weeks of arginine, 2 weeks of MI paste. So all the time you're using different tubular blockers to block. So you may ask me, if you're blocking the tubules, then how can the whitening work? Because the whitening gel is even more, it's very, very tiny, and the oxygen can bypass the tubular blocker. The potassium nitrate works by stopping the excitation of the nerve. So it stops repolarizing of this nerve over here.
Yeah, but
and so we need to just mute somebody over there.
What are you going to do now?
Okay.
Oh,
can you just check that down?
All right.
Okay. Just have a look. Sorry.
All right. Yeah.
Okay. I think everybody's muted. Sorry. And so what we're looking at in the cervical area is the fact that the cervical area is very close to the pulp. So what we do when we see a patient and assess them, we would spray air onto all the cervical areas of the patient's tooth when we're doing a new patient exam. And we would go through and we say to the patient, is this sensitive? Is this sensitive? And we'd mark on our notes which were the teeth that are sensitive when we are blowing air onto the teeth, because those are the ones that are possibly going to be sensitive during whitening. Mm-hmm. So which groups are do they find have the most sensitivity? This was a study called the Escargot Study, and that was by, of course, GSK undertook the study because they wanted to see who would be using their toothpaste. So they looked at the under 18s and they showed there was some evidence of erosion on the first molars and the buccal cusps. The 18 to 25-year-olds, there was some evidence of erosion, but the biggest one was the the 26 to 35-year-olds had the most erosion and the most dentine sensitivity. So those specifically would be your patients, again, who really want to whiten, plus they've got sensitive teeth. So we need to be managing the sensitivity prior to undertaking the whitening, not expecting the patient. We have a protocol first to manage it. Then there's another category which all of you need to look at, the 51 to 69s. Those are now called the super boomers. Now that lockdown is about to finish, you should be calling up all your super boomer patients who've now been vaccinated and ready to have aesthetics and restorative. And those are the patients specifically we can manage. They don't have as much sensitivity, but we can manage the expectations and look at their erosion and their tooth wear to be able to have a successful whitening. So the new research looked at these age groups, and the buzzword is the NCCL, non-care cervical lesions. 20 years ago, we didn't see so many NCCLs. Now we have so many patients with NCCLs. It's sometimes more prevalent on some of our patients than tooth decay. And I feel that we shouldn't be leaving them and getting the patients to just to avoid it and brush, because they're brushing deeper and deeper, and these lesions are getting deeper and deeper due to the clenching and grinding. So this was the study, the bourgeois study that looked at that. So we looked at all ages of teeth can be sensitive. So we need to be examining, do the thorough examination, and also do a dietary analysis, look at the sensitivity and the pain on brushing, and the brushing techniques and the brushing methods. Is it the root that is exposed? Is it because the dentine is exposed? Is it because the gingiva is there's gingival recession or gingival sensitivity or very thin gingiva, or is it multifactorial tooth wear? So we mentioned all the different etiologies which we looked at, and do remember all these reasons why the patient may be sensitive. So there's different treatment modalities for managing sensitivity. Number one would be a passive way, where you would observe and monitor, look at the history of the etiology and understand what's happening. And then you would apply varnish. So you can use the fluoride varnish. You can get the patients to brush with a desensitizing toothpaste, or um, you can get the desensitizing toothpaste either massaged onto the tooth or brushed with it. And these are some of the ones we use: Sensodyne, Colgate Pro Relief, the Reman Pro, the Rox material, the MI Paste, the ACP as well. And you have the enhanced the mousses and the varnishes to add. And every single patient that we administer a whitening treatment would have a proprietary brand of soothing material. So they have their samples that they go home with, and they have a proprietary soother, which we're going to talk about. So you would apply, if you're doing the active method, you would apply the materials onto the sensitive teeth, adjust the tooth if needed. If there's a fracture or there's an issue, you may want to put bonding agent if it's on a lower incisor where the patient is bruxing, and that is really sensitive during whitening. You may want to use a glue, mahim, or potassium oxalate, which is, for example, in Hurry Seal. Or we make the therapeutic trays, and we do the therapeutic trays where we apply the soothing materials, the proprietary soothing, for 2 weeks prior to bleaching. Bring the patient back and review. We have currently 2 patients that are not whitening who are having therapeutic trays for, 3 who are having therapeutic trays for desensitization. Because I don't feel we should just say, oh, you're one of the guys that has sensitive teeth, and just leave it at that. I think we should do an active protocol. And then I want to look at how we would place on class 5 lesions the resin modified glass ionomer. So we mentioned you can rub it on with your finger, use a soft brush, or put it in the bleaching tray, such as Reman Pro or the tooth mousse or MI paste. The difference between the tooth mousse or the MI paste is that the tooth mousse doesn't contain fluoride, and the MI paste has fluoride and ACP. So here, Diane is showing her patient how to apply the tooth whitening, the soothing gel, into the patient's retainer for the purpose of soothing the teeth. So often the patient's bleaching trays are overextended. So they always at each appointment need to bring their trays with them. And here you can, where it's overextended like this, you can cut back. This pair of scissors is really excellent. It's from Ultra Trim, from Optident, and they're brilliant for cutting back like this. Another treatment that we use is Hurry Seal. And Hurry Seal is a proprietary soother with HEMA inside. So we would drip on to the cervical area, the sensitive area, and we air dry, and we drip and we air dry to reduce the sensitivity. And even during whitening, if it's sensitive, we would put the hurry seal on when we're assessing our patients. So here is a patient who has got these silver areas, which are from the occlusal amalgams showing through. I'm just showing you that the mercury is released during whitening, and it's important that we acknowledge that for patients, but not cause harm and worry by over alarming them. And then we need to look in terms of what shade are we going to go, because the lighter the shade, it may take longer, and sometimes it's not possible. This is the Bleaching 3D Master Shade Guide that we should be using, because you have the value shades. So it's very scientifically assessed. These are the shade differences. So a shade 29, if it's 3M3, which is like a B4, and you go to a 1M1, that is 24 shades. And this can be scientifically measured, which is a brilliant use for us to measure scientifically our patient shade that can be achieved. This shade is not on the shade guide. It never will be on the shade guide, but it's a shade that it seems that these contestants all wanted. And if you look, these are the current ones from last year. You can look at their shades of teeth and you can see that this one is like toilet bowl blue, but actually not on any shade guides that we see. These are the previous Love Island contestants. Now, what I'd like to talk to you about is my protocol for resin modified glass ionomers. So once I have gone through with a patient and assessed that they have sensitivity to cold on an area where there is a NCCL we would place a resin modified glass ionomer. And the reason we like resin modified glass ionomer is its adherence to dentine, which is, I think, is much easier. It's easy to place. You then don't get a black line where there's leakage, and it's quick to stop the sensitivity. So the protocol would be that we would clean the cervical area, and the way we would clean the cervical area, sometimes we need to sandblast, or we use the AquaCare machine where we are jetting in silk, which is also a soother. We would need to isolate, so we would either isolate by retraction. We would sometimes need to use a double retraction because the gingiva has grown into the NCCL. Then we would need to clean the cavity and make sure there's no residual plaque. Then after all the sandblasting or AquaCare, we would pumice and scrub with a micro brush. Then you check again with a probe, because often, because of the deep vertical groove, there's still plaque in the groove. So we would go back and clean it. When we were going to etch it, we would double etch. Because of the sclerotic dentine, we would apply hurry seal, and then we would go straight on to apply the resin modified glass ionomer. My one of choice at the moment, you can either use Fuji or Riva. I like Riva, just Riva straight, shade A1, because it's very liquid, and you can paint it on, and you dip your brush into resin and you sculpt it straight away. Use a probe and probe around, and you get a beautiful contour. So these are the different protocols that you can, if you don't treat them, what you're going to do, you're going to leave it. They're going to get further sensitivity. Some of them have secondary tooth decay because there's food accumulating. It gets deeper because of the more bruxing. And so my particular protocol is to treat them early so that they don't develop into deep lesions, and just sort it and stop the sensitivity. So now these proprietary soothing materials, and there's quite a few on the market. There's 3 specific ones that we use. Those would be the Polar Soothe, which is from SDI, the Relief Gel, which is from Philips, and the Ultra Ease, which is from Optident. Ultra Ease contains potassium nitrate. The Polar Soothe contains potassium nitrate and fluoride, and relieves the sensitivity by depolarizing the nerve from the one aspect and blocking the tubules from the other. But every time we do whitening, we administer 1 syringe of a soothing gel. And the way the patient would use it is they'd use it half an hour before whitening, half an hour after whitening, or half an hour instead of whitening. And that way they can manage the sensitivity very easily, and it doesn't become a major issue. So before, during, or instead of whitening, contact time would be 30 to 45 minutes. One of these syringes is about 14 pounds or 10 pounds, so you need to add that to the cost. This is your relief gel from from Philips. And the beauty about this is it also contains amorphous calcium phosphate. So in one of the syringes is the ACP, and the other syringe is the potassium nitrate and the fluoride. So when you mix it together, it mixes fresh every time and so is effective. And they put this into the bleaching tray. And this really makes a difference for the patient for soothing. This is the Ultra Ease, which comes either as a syringe or as an applicator, which is a disposable applicator that a patient would use for half an hour first. Again, 3% potassium nitrate and 0.1% fluoride, and it's very viscous. It stops the sensitivity and is very useful to add to your bleaching. So if the patient has a history of sensitivity or you touch the air, you would plan to do some type of relief to give them the soothing materials, soothing toothpastes, soothing applicators, and then you would fill in with the resin modified glass ionomer as well. ACP has benefits, that's tooth mousse or MMR paste because of remineralization, can help with the reversal of caries. It helps with white spots reduction as well. And it blocks the tubules, and it also, because it blocks the tubules, also helps with the, it precipitates into the defects of the enamel, and so you get a beautiful lustrous surface. We would use ACP specifically after microabrasion as well when we're brazing the surface of the tooth. So on this particular patient who had sensitivity, we did gingival grafting, and this was undertaken by Dr. Richard Horwitz, the periodontist who works with us. And you can see that's a very nice result. But it's more invasive for the treatment. So tetracycline patients are not tending to be sensitive, but we can tell these patients, tetracycline patients, because of the deep orange areas on the necks of the tooth. And they would take longer. On this particular patient, they may be sensitive into these recession areas, so you can assess that. This is silver nitrate, silver diamine fluoride, which really makes a big difference in sensitivity and specifically for tooth decay. Really a lot of research on this we've just published on silver diamine fluoride and its use in dentistry. So there's a lot of patients who can benefit from an approach of soothing and desensitizing, making therapeutic trays. This patient was not really interested in whitening, but we need to assess and manage their severe wear that they have. So the resin modified glass ionomers, let's just talk a little bit about them. These are the researchers early on that undertook the research. They have benefits in that their bonding to dentine is really excellent. The combination of the glass ionomer together with the resin gives you the aesthetics, and the glass ionomer gives you the adhesive properties. So we would use it for all these different patients, and we do a lot of these. Here we are putting in the ACP in a patient's bleaching tray to modify. But these are all the areas when we would use Riva Light Cure. There's two different versions. Riva HV is for posterior, and that's more opaque. But our choice is an A1 Riva Light Cure, A1 Riva LC, and here you can see how we were able to treat it. But these are all the indications for resin modified. So we would use the pumice and heavy scrub just mixed up on our own with a micro brush for polishing inside. Here we are with the patient using the trays like this. And these are some of the other toothpastes. So I just want to come onto the stages where we cleaned it. And there's some pictures here. So here we are etching the tooth. We are applying we dip in the brush. So we apply the resin modified glass ionomer, and then we sculpt with the bond. We sculpt along here. We do a probe where we probe nicely to help us with our sculpting. We place the brush, and then we light cure. Very quick and simple, but very effective. Here's a little video just showing how we were able to do that on a model. But it's really quick. Here's the AquaCare. The video's been speeded up in case you think we're very super fast dentists, but it's been speeded up. And here we're applying the Hurry Seal onto the surface of the tooth. And then we would mix the resin modified glass ionomer. It's shade A1. They even have a B1 shade. And we're sculpting like this with the probe before you light cure. The beauty is it's very translucent, so it blonds on very, very nicely. It's quite viscous, it's not thick. And then you just use your flame, and the last thing you do is you would put on a rubber wheel to polish these just up to nice polish, and you would take off your retracted trays. So I think basically that's a good summary of how you manage sensitivity, and I hope that is helpful, and I'm happy to take questions.
Thank you, Linda. That was great. Very nice systematic approach. So thank you very much. I'm sure it was useful to everyone. Any questions?
I haven't seen any questions in the chat. Do you want to look at the chat? I don't know if anyone wants to.
There's none in the chat actually.
Can't see anything. I can't get into the chat.
I can get in, but there's none. But feel free to unmute yourself and ask a question. Yeah, we need a bit of interaction.
Yeah, let's not all be so quiet.
Yeah.
Okay, I'll kick off. You mentioned the Vita 3D bleaching shade guide.
Yes.
The age-old question, which is always very difficult to answer for that particular guide. What's the equivalent in terms of number of shades for a typical result? Because we're all very familiar with the 8 shades of improvement you get with the standard Vita shade guide and value order. So what's the equivalent on Raddy's one?
So recently, we had the team from Vita come to our practice. This was before lockdown, because we have moved on to the Vita Easy shade. I think I can hear an echo.
Yes.
Everybody can mute themselves again. Not you, Chris, it's okay. No, I'm teasing. So basically, to answer your question, the Vita company think that the Vita Classic is too old-fashioned to use as a shade measure. And because of the fact that the shades are not arranged linearly, it's not effective. And we do get 16 shades change. We can get it. We don't do it always, depending on the patient's shade. But we can get 16. But you see on the Vita A3, sorry, the Vita 3D Master, we can get more than 24 shade changes. Awesome. And the beauty about this is that you've got half shades and half measures, and it's a linear arrangement. So you can scientifically audit all your patients that have had whitening according to the Vita 3D Master. You get much better results. You can publish these because it's a scientific measure. Does that help, Chris?
Not particularly, because I've read Raddy's papers on it. I've asked him directly, and he goes, "It's in the papers." And you read the papers, and he says that he gives you the answer. And I'm probably not intelligent enough to read them, that I can't get an equivalent. And I can't sit down with a patient and say, "Okay, so we've measured your teeth with this particular shade guide. I know the 3D is much more accurate for all sorts of reasons that we don't need to go into, but it's far superior to the Vita classic shade guide." But it's very difficult to say to the patient, "This is how many shades of improvement you're going to get in this shade guide. Whatever number it is, it has to be good." Why they added half shades in, so that you could have. I don't know what the number is, but it has to be bigger than 8. Otherwise, the patient goes, "Well, the guy down the road is saying 8 shades," and then you go, "Well, he's using a different shade guide," and it just gets very complicated.
So
I'm suggesting that I need to nag Raddy to publish something a little bit more down to earth for normal people rather than his usual stuff.
So Chris, what I would recommend is the Vita Easy shade, to purchase one of those.
Oh yeah, I have 2 of them actually, version 2 and the version 5 by default.
And so those are much more accurate. And what we like about that is that you've got a Bluetooth to record it. So I find those quite useful. They make it more specific, the shade changes and the shade measures.
Absolutely, and you can go down to delta E values on the teeth if you want to. If you want to be that scientific about it, it's probably not a bad thing to do actually. Anyway, these guys, I'm sure other people have questions. Thank you.
Thank you.
There's a couple.
There is a couple of questions in the chat. I'm not sure where the echo is coming from. Sorry about that. One from Paulette, who's in Australia. and she has the benefit of being able to use any strength of gel that she wants. And her question is, do you ever offer in-chair jump starts with a stronger product first, i.e. 25 to 40% hydrogen peroxide? That seems to be most popular service in Australia.
Okay, so just thank you very much for that. Actually, the 2019, I did a lecture tour in Australia, and it was really interesting to chat to the dentist about the use of such strong materials. I'm just trying to see how we can make it. I just want to see who's got this.
I've done it, Linda.
Okay, fine. Thank you.
I'm just keeping an eye on it.
Okay, fine. So there's no benefit in using high concentration for doing motivational top-ups. It makes no difference whatsoever. You can use much lower concentration as a quick start in the chair. You can start off with a 6% hydrogen peroxide, and what we normally do is we would we fit the bleaching tray, because we have a duty and responsibility to fit the bleaching tray for a patient. So we show the patient exactly how much gel to use. We then get them to take a photo on their phone of the bleaching gel in their tray to see exactly how much, because they forget how much to use. Then when we administer the tray in the mouth, and then we go through the rest of the consent and the questions and the discussions, and that's at least 10 minutes, by which day there's already some change that has occurred. So you don't need to use a high strength quick start. The high strength quick starts are just very, very strong, but at the end of the day, a day later, you don't really see a major difference, because the shade change has been so rapid. The research has shown it doesn't make a huge difference. This low and slow way shows that you reach the bleaching potential. What you are doing is you're bleaching the enamel, but you're also bleaching the dentine. On the home bleaching, you're specifically bleaching the dentine. On the power bleaching, you're bleaching a little bit of the enamel, but in that 1 hour is not enough to be the wow effect that really makes the difference. A lot of it is just hype and dehydration that you are seeing. So what it may do is actually the patient may be disappointed, because the next day they're doing home bleaching and there's not this wow dazzling effect, because the teeth are not so dehydrated. And when I spoke to the Australian dentists, I went all around the country. It was great fun when we were allowed to travel. And we spoke about this concentration. And many of the Australian dentists give 10% hydrogen peroxide as they take home, which is equivalent to 30% carmide peroxide as a take-home. It's not necessary. Just because you can do it in 4 days doesn't mean the result is going to be long-lasting. So we use the Van Hayward Protocol, and the Van Hayward Protocol was published in 1989, and we haven't changed the protocol. And the way that the protocol works is you bleach the upper teeth first for 2 weeks, patient comes back, and you use the carmide peroxide, which is the slow-release oxygen agent. All the way through the night with carmide peroxide, over 10 hours, the oxygen is being released. But the benefit of this product is it contains urea. Urea elevates the pH and helps with wound healing and helps with root decay and tooth decay reduction. Hydrogen peroxide on its own doesn't. If you're using a hydrogen peroxide only or a day product, all the oxygen is released within half an hour. So it may sound like a fun thing to do, but actually it's not necessary. There is a new product in the European market, which is 16% carmide peroxide. It's called Blank One. And that is a 10-minute treatment, which is fun because it has red bubbles. You don't need to use any retraction, and you don't need to use any protection. And that is a really nice quick start. So a lot of our hygienists will do that after the cleaning. They'll administer 10 minutes of 16% carmide peroxide as a chairside, which is, as I said, red bubbles, and it's very exciting, looks very pretty, and that can motivate. If what we are doing is motivating our patients, that's great, but that's why we spend time discussing and seeing our patients and bringing them back. So we're building up trust with the patient so that they fully comply with the methods that we want them to do. The photo of the patient, this is from Eleanor.
Yeah, so have you got that question, Linda,
yes,
just about the discolored buccal cracks?
Yes, so the black cracks do not change a great deal. If they have the black cracks, It may go to a brown crack, but it's not going to disappear with whitening. And we need to be very clear with the patient what's going to happen and what's not going to happen, because those are not going to go away. If those are very severe, you can use resin infiltration to protect the teeth, but it's not going to really make a significant difference with whitening. So I hope that answers your question. So now we're going to go to Kath's question.
Yeah.
Can you review if somebody has a non-vital tooth?
Do you want me to read it?
You know,
It's here.
I'm reading it. Has not signed on PAP. I'm not sure what PAP means. Would you do here? So basically, on a non-vital tooth, most of the time we would do internal bleaching, where we do sealed in bleaching. But sometimes on our reviews and top-ups, we would just do external bleaching. On those patients, they do regress the shade because the stain is in the root dentine. And if the shade is in the stain is in the root dentine, that takes longer to bleach. So on those specific patients, we may do top-ups every 6 to 9 months, 3 days on a non-vital tooth to bleach. But we can normally would make a sectional bleaching tray, and then we would make and they would do top-ups every 9 months on that. The consent forms, Diane will send consent forms. Oh, that's amazing. Paulette was at the lecture. Which city were you in? So low and slow, we would do, there is a 5% carbamide peroxide, and 5% carbamide peroxide, that comes from Novon Mild, and Novon Mild is produced by Optident. And the benefit of that, it has tripolyphosphatase, which is the soother, which is also incorporated in many of the desensitizing whitening toothpastes. And so we would start 5% first, then we would go to 10%, and then we'd go to 16% if we were doing a tetracycline case. But 5%, especially on patients who've tried every single bleaching agent and have been sensitive, or it's been difficult for them to tolerate the trays, we would use 5% carbamide peroxide. It's called Novon Mild. We would also use Novon Mild for patients who have medically compromised, on elderly patients, on super sensitive patients. That's when we would use 5% and start on 5% and then go to 10%. Often patients are more sensitive on the lower, so that we would do 5% there and then we would ramp it up. So Paulette, just to come back to your discussion, it's us. Melbourne was a really nice city, and I had my family there. It was a really nice city, a very nice vibe there. I know that the companies hype it up, but it's really up to us when we are marketing to our own patients, that we sit down and explain the reality to our own patients. So they may see all this hype on TV and Instagram, but you've got Instagram, which is awesome. And just by the way, my one's called Greenwall Dental. But on Instagram, you can do all your marketing and explanations and talk to your patients and tell them the reality. We have a duty to be real with the patients and not tell them it's awesome if it's not going to make a difference. We have to be very genuine and be very direct into exactly what will happen and what won't happen. And the other thing we need to tell patients is that often it is we don't know until we start bleaching. That's why we need to bring the patients back 2 weeks later to assess them. Is that all the questions, Zaki? Okay, great. All right.
That's it, yeah.
Thank you. Anyone else? Diane will send you all the information.
There's one more just come in. Do you use hydrogen peroxide much?
No.
Sorry. We don't use the day product much. We would only use it for when we're doing small top-ups. But most of the time we stick with the low and slow, the carbamide, because carbamide has these extra benefits. Carbamide's got urea in it. So urea elevates pH and it improves the healing of the mouth and the wound healing and the root decay and the tooth decay. So even if we're using it for an hour, we prefer carbamide. Plus it's got the elevation, the pH, the long lasting. We prefer carbamide to hydrogen peroxide.
So, I'll just add one thing to that. The only time I use day whitening or hydrogen peroxide is if someone is a bruxist, a heavy bruxist, because with the soft trays, either I make them hard trays like Invisalign or Essex retainer type trays. But if you use the soft trays on a bruxist overnight, they're literally grinding and the gel's coming out, saliva's coming in, and it doesn't work that well. So that's kind of the only time I use it. Do you use that sometimes, Linda?
Yes. For those specifically bruxes, we actually much more concerned about bruxes now, because I've seen on 3 patients with a small little cracks on their molar teeth that a few years later they have needed root canals on those teeth that were previously bleached. The research shows on a bruxer about 3% over a long term, like 17 years, may need root canals after this. It's the bruxing effect with the micro cracks, not from the bleaching. The bleaching doesn't stir it up, but we need to just be aware of that on our patients.
And the biggest people with sensitivity are the bruxists as well, aren't they?
Yeah, because of their micro cracks. And so often we would have a different protocol, making sure they have their ACP and their tooth mousse, but also applying the HEMA to stop the cracks, to just protect the teeth more during the procedures as well, during inter canal medications kind of treatment. Basically, when we see them and review them, we check the sensitivity at each appointment.
Okay, I think that's it. So Linda, thank you very much.
Thanks so much.
Yeah, so thank you everyone for turning up and persevering with us. I thought it was really interesting, and hope to see most of you very soon in the flesh.
Very good.
Thanks so much. Thanks a lot.
Thank you, Linda.
Thanks so much.
Thank you. Bye. Bye-bye.
Bye.